Hello,
Hello, Manu,
hello, am I
Dr.
audible?
Good evening. We'll start by 7:30.
Okay.
Welcome.
Uh,
Good evening, sir. Venkateshan, sir.
Good evening. പതിനഞ്ച് പേരായില്ലേ?
ആയിട്ടുണ്ട്. ഡോക്ടർ തോമസ് ജോയിൻ ചെയ്തോ?
oh, I think,
Good evening.
Good evening.
ഡോക്ടർ എബി ജോയിൻ ചെയ്യോ? എബി ചേട്ടൻ
എബിനെ വെയിറ്റ് ചെയ്യണ്ടെന്ന് പറഞ്ഞു.
ആണോ? ഓക്കെ. അപ്പം വിൽ വെയിറ്റ് ഫോർ എ ഫ്യൂ മോർ ടു ജോയിൻ. ഇപ്പൊ 16 ആൾക്കാർ ജോയിൻ ചെയ്തിട്ടുണ്ട്. ഫ്യൂ മോർ 5 minutes വെയിറ്റ് ചെയ്യാം. ഓക്കെ. മനു, ഷെയർ ചെയ്യാൻ പറ്റുന്നുണ്ടോ? ഷെയർ ചെയ്യാനുള്ള ഓപ്ഷൻ വരുന്നുണ്ടോ മനു? കോ ഹോസ്റ്റ് ആയിട്ട് ആക്കിയിട്ടുണ്ടോ എന്ന് നോക്കട്ടെ.
ഹലോ.
മുരളി ചേട്ടാ, ഗുഡ് ഈവനിങ്.
പറയൂ. ഞാന്
ഗുഡ് ഈവനിങ്.
ഒരു മീറ്റിംഗിലായിരുന്നു.
അപ്പൊ നമുക്കൊന്ന് തോമസിന് ഇത് ഗ്രീൻ സിഗ്നൽ കിട്ടിക്കഴിഞ്ഞാൽ വി ക്യാൻ സ്റ്റാർട്ട്. കുറച്ചുകൂടെ ആൾക്കാരൊന്ന് ജോയിൻ ചെയ്യാൻ വെയിറ്റ് ചെയ്യുവാണ്.
20 ആയിട്ടുണ്ടല്ലേ? ഡോക്ടർ മനു, ഹായ്. ഗുഡ് ഈവനിങ്. സക്കീർ സാർ ഉണ്ട്, ഹായ്. ചിതാമഠം ഉണ്ടല്ലോ, തൃശ്ശൂരിൽ നിന്ന്. വെങ്കടേശ്വരൻ സാർ.
Good evening.
ഗുഡ് ഈവനിങ് സാർ. ഗുഡ് ഈവനിങ്. മനു, കോലഞ്ചേരിയിൽ നിന്ന് നമ്മുടെ ക്യൂസിന് ആരെങ്കിലും ഉണ്ടെങ്കിൽ പേര് തരാൻ പറയണേ. PGs. മനു മ്യൂട്ടഡ് ആണ്. നമുക്ക് സെപ്റ്റംബർ 7th തൃശ്ശൂർ മെഡിക്കലിലാണ് നമ്മുടെ നോർത്ത് സോൺ PG ക്യൂസ്. ഇപ്പൊ ഒരു 7 ടീംസ് ആയിട്ടുണ്ട്. എറണാകുളത്ത് തന്നെ 3 ടീമുണ്ട്. അപ്പൊ കോലഞ്ചേരിയിൽ നിന്ന് ഉണ്ടെങ്കിൽ എന്നെ ഒന്ന് അറിയിക്കാൻ പറയണം കേട്ടോ.
27 പേരായല്ലോ. 28.
നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം, ഷോർട്ട് വൈൽ സ്റ്റാർട്ട് ചെയ്യാം. തോമസിന് ഇന്നൊരു ഗ്രീൻ സിഗ്നൽ കിട്ടിയിട്ട് സ്റ്റാർട്ട് ചെയ്യാം സർ.
ജിനോ സ്റ്റാർട്ട് ചെയ്യാൻ തോന്നുന്നു, അല്ലെങ്കിൽ നമ്മൾ ലാഗ് ചെയ്യും. കാരണം
ഓക്കെ ഓക്കെ ഓക്കെ
ഈ 20 മിനിറ്റ്സ് ആണെങ്കിൽ തന്നെ നമ്മുടെ ടോപ്പിക്സ് ഒക്കെ വലിയ ടോപ്പിക്കുകളാണ്.
Okay,
ലാർജ്
okay.
ടോപ്പിക്സ്
Okay,
ചിലപ്പോൾ
yeah.
ടൈം ഓവർ ഷൂട്ട് ചെയ്യാൻ സാധ്യതയുണ്ട്.
So, welcome to all. Good evening to all. So today we are kickstarting the Essential Newborn Care program, and today is the first of the online classes. So today we have three presentations on the common topics in neonatology, including respiratory distress in a newborn. Then we have neonatal hypoglycemia and neonatal hyperbilirubinemia. All three are important topics. So we'll move on to the first topic, that is approach to respiratory distress in a newborn. We have Dr. Manu Rajan, who is a neonatologist in MOSC Medical College, Kolanjeri. Welcome, Dr. Manu. And I think we'll start with the first session with the permission of all. Thank you. Dr. Thomas, നമുക്ക് മനുവിന് ഷെയർ ചെയ്യാൻ പറ്റുന്നുണ്ടോ?
മനു മ്യൂട്ടാണ്.
Thank you, Dr. Gino, for the warm welcome. Yes, Gino, the sharing mode is now enabled. As Murali sir has pointed out, we have big topics for today. So I will be trying to do justice to my topic, and I have trying to present approach to respiratory distress in newborn. Okay, first of all, greetings. Is my presentation screen visible to all?
Yeah.
Yes.
Yes,
First,
it is.
greetings to all of you from Department of Neonatology. I am Dr. Manu Rajan Edukula, Assistant Professor in Department of Neonatology and Medical College. And today I am going to present an approach to respiratory distress in newborn. Now I'll be covering definition, common etiologies, assessment of distress, investigations, and how to initiate management in the case of respiratory distress in this 20 minutes. Respiratory distress is one of the most common reasons for an ICU admission of an unit. And the incidence of respiratory distress is more than 30% in babies less than 34 weeks of gestation. So you can see that as gestation age decreases, the incidence of this respiratory distress increases. It is around 5% in term babies and 15% in late preterm babies. If you are going to define respiratory distress, it is the most common features that can be seen is tachypnea, work of breathing, grunt, and central cyanosis. So we have to take care that a baby should be properly undressed and should be examined for a full minute before coming to a definition of respiratory distress. As you know, tachypnea is defined as respiratory rate of more than 60 per minute. And babies can have periodic breathing. So if you don't count for one full minute, you are prone to make an error. Work of breathing is the retractions present in the baby. It is the axillary muscle use. There can be subcostal retractions, intercostal retractions, which may present, which is showing the increased work of breathing. A grunt is a partial expression through a partially closed glottis, and it is a telltale sign that the baby is trying to maintain its functional respiratory capacity. Along with that, cyanosis shows that the baby is having hypoxemia. So all these are like features of respiratory distress syndrome. If you have more than two, you can say that patient is having respiratory distress. There are various etiologies for respiratory distress. I have put together some of the common ones. So in airway, the most common ones are like nasal obstruction, funnel atresia, sometimes a pericardial sequence you can see. In the pulmonary system, you can see that RTS, transient tachypnea of newborn, meconium aspiration syndrome, and neonatal pneumonia or pneumothorax can present as respiratory distress. Thoracic causes like a pneumomediastinum, chest wall deformities, diaphragmatic hernia. Cardiovascular causes like cyanotic and select cyanotic congenital heart defects can present as distress. Neuromuscular causes like a CNS injury, hypoxic ischemic encephalopathy can all present as disease. But we should not forget other small causes which are more common, like hypothermia or hypothermia which may be present in the baby, and anemia which can be present, or sepsis, hypoglycemia, or metabolic acidosis which is present at birth. All these can cause respiratory distress in the initial stage. As with all other medical conditions, we have to take a look at the history. We can divide it as antenatal, natal, and postnatal histories. The antenatal history, we should take a look at confirm the dates before initiating treatment. We should take a directed history regarding any maternal complications which can give rise to distress, like maternal diabetes. If it is a preterm baby, whether the mother was given antenatal steroids, any signs of infection in the babies like PROM, chorioamnionitis, whether the mother was on any medications, all these things should be checked for. Natal history, you should be checking regarding the mode of delivery. How was the baby delivered? Was mother given any sedation? Was there any resuscitation required? What was the color of amniotic fluid? Postnatal history, what is the onset, progression, duration of the distress? All these will give clinical clues to the etiology of the distress. Now, I am compiled a chart showing the most common cause of respiratory distress and its risk factors and onset and so forth. So first is transient tachypnea of newborn. Transient tachypnea of newborn can occur at any gestation. Onset is usually immediate to within 2 hours of birth. Risk factors are usually cesarean delivery, maternal diabetes mellitus, maternal asthma, male sex, or macrosomia. Respiratory distress syndrome, usually in a preterm babies. Onset is usually immediate. Male sex, maternal diabetes can predispose baby to respiratory distress syndrome. Meconium aspiration syndrome can occur in term or post-term babies. Usually the onset of distress is immediate. Usually we will get a history of a meconium stained amniotic fluid. Infection, maybe sepsis or pneumonia, can occur in any gestation. Distress usually is slightly delayed, and we may get a history of prolonged rupture membrane, maternal fever, group streptococci. Then pneumothorax. Pneumothorax can occur in any baby. Distress is usually at the onset of pneumothorax. But the thing is, usually this baby suffering from some other etiology. So pneumothorax will worsen this. Artificial ventilation is a risk factor. A delayed transition can cause respiratory distress. It can affect both term and post-term babies. Any congenital heart disease can cause respiratory distress. It can affect any gestation. Now, this is the good time to introduce a small algorithm. So it's a simple algorithm which I got from one of the articles. So we have a newborn who presented with respiratory distress. We have considered the maternal and patient history. The next step is to assess the degree of distress so that we can tell whether it is a severe distress or a mild distress. Now, for assessment of distress, it is always beneficial that we follow a TABC approach in the beginning. We should look at the temperature, whether the temperature is maintained. We have to see the airway, whether it is patent, whether there is any abnormal sounds coming. How is the breathing of the baby? What is the rate of breathing oxygen saturation? What is circulation? What is the baby's heart rate? Is the perfusion normal? Disability, how is the tone and consciousness of the baby? So if any of these is abnormal and requires immediate action, we have to go forward with that. Otherwise, we can have some time and we can go to a systems examination. We have to look at the respiratory system for respiratory work of breathing, any grunt, retractions. We have to auscultate the baby. Cardiovascular system, we have to look for perfusion, femoral pulses, cyanosis, murmurs. Then you can look for a scaphoid abdomen or any other surgical causes. We can look for neurological status of the baby. Now, the main objective of our system examination is to delineate a non-respiratory cause of respiratory distress. Now, we have simple tools for monitoring respiratory distress. The Silverman-Anderson score has been around since the 1950s. It is mainly a retraction score. As you can see, it has upper chest retractions, lower chest retractions, sigmoid retractions, nair dilatation, and expiratory grunt. And any score above 7 is considered as a severe distress. Down score came in the 1970s. This, if you look closely, it has the grunting and retraction. Along with that, they have added 3 more components, that is respiratory rate, cyanosis, and iron ring. If the Silverman-Anderson score mostly is used in preterm babies. Down score can be used in all gestations, probably. Now, any score more than 7 is considered as a severe distress. So once we have assessed the degree of distress, we have to see if there is immediate action required. You have to go for immediate action. Pulse oximetry, supplementary oxygen, chest radiography, other investigations has to be done. The baby is having only mild distress. We have some time to see how the baby is, monitor the down score or Silverman-Anderson score, see how the baby is progressing, and watch for clinical improvement. If there is a clinical improvement, we can treat based on the results. If we don't have any clinical improvement, we should go forward with more testing. We should go forward with a definitive treatment strategy and supportive care. Now, I have to put in one word regarding pulse oximetry. By far, pulse oximetry is one method for continuous monitoring of a newborn baby. Pulse oximetry shows us the saturation, oxygen saturation of the patient. Now, we have to have a basic idea of how the pulse oximeter works. It works on the principle of the Beer-Lambert law. Actually, the oxyhemoglobin and deoxyhemoglobin have various differing absorbance of red light and infrared light. Now, this can be measured using a photodetector, and the results can be computed to a monitor as a saturation and a pulsatile waveform. Now, the saturation probe has to be kept in the right upper limb for a preductal saturation and to be kept in the lower limbs for a postductal saturation. It is useful at this time to note that the preductal saturation after birth improves to 85 to 95% only by around 10 minutes of life. So when you have a baby who has come immediately to the NICU with desaturation, it is always useful to have this concept in your mind. Now, what are the limitations of pulse oximetry? Pulse oximetry has limitations. One of the most common limitations are artifacts. If there is a movement, if the baby is crying, can cause false reading. There is a response delay for pulse oximetry. It's especially evident during rapid desaturations. Pulse oximetry requires a pulsatile
അതിപ്പോ
blood
ചെയ്യേണ്ട
flow.
ഔട്ടുമണി ഇപ്പൊ എന്തെങ്കിലും പഠിക്കേ
Requires a pulsatile
മുഴുവൻ
blood
അവള്
flow
പ്രാക്ടീസിന് പോയ നോട്ട്സ് എഴുതിയിട്ട് സമയം അങ്ങോട്ട് കളയാന്ന് വിചാരിച്ചു
for its working. Poor perfusion affects the measurement of saturation. It cannot detect hyperoxia. It cannot detect partial pressure of carbon dioxide. Now, regarding hyperoxia, also I have to put in this oxygen dissociation curve. As you can note, by around 80 to 100% of PeO2, the saturation will be showing around 100%. Even if you are providing more and more PO2, it will still be showing 100% only. So you can easily miss the hyperoxia preterm, especially when the baby is not supported. Now, once we know that the baby is desaturating, baby is having distress, we have to go forward with investigations. The most common investigations are chest radiograph, electrolytes, blood glucose, hemoglobin, a sepsis workup which includes CBC, total count, CRP, and a blood culture. ABG analysis is a very important tool. Lung ultrasound, if available, you can do a lung ultrasound and determine the etiology of distress. Special investigations like echocardiography, neurosonogram can be used where indicated. Now I am putting some chest radiograph of the common respiratory scenarios. Now this is a diagrammatic representation of transient tachypnea of newborn. You can see that there is a fluid in fissure. Sometimes there may be a little pleural effusion. We can see multiple linear densities in the perihilar region. There may be subtle cardiac enlargement and a mild increased lung volume. An actual X-ray might look like this, showing the perihilar, the lung fluid. RTS can show bilateral ground glass opacities, can show air bronchograms. There is poor differentiation of cardiac order and vessels. There is decreased lung volume. RTS can show various X-rays because it is an evolving disease. It depends on the time at which the X-ray is taken. However, severe disease can usually present with a whiteout lungs. Meconium aspiration syndrome is another condition where you can have highly variable X-rays. It depends on the meconium which has gone in. It depends on where it is lodged. So you can have coarse patchy densities. You can get a fluid in fissure. You can have an area of atelectasis. You can have air trapping, hyperinflation, sometimes even a pneumothorax. There may be subtle cardiac enlargement. There's an X-ray of pneumothorax. Pneumonia also can get a low to normal volume lungs, can have patchy atelectasis. Sometimes there may be a frank consolidation present. Pneumothorax is also a common condition, especially if the baby is on artificial ventilation. You can see increased lucency on the area of pneumothorax. You can see that collapsed lung border. There may be a mediastinal shift, but all pneumothoraxes need not be so evident. This is an X-ray of a baby having pneumothorax, which was confusing even after the X-ray, but sometimes a transfiltration can help in detecting the pneumothorax. This is a simple, quick, and effective. Blood investigations always do electrolytes, including bicarbonate, if you are suspecting a respiratory distress, especially if you have history of a difficult delivery. Doing a bicarbonate can easily give you clues regarding a metabolic acidosis, which needs to be corrected. Get a hemoglobin if you are suspecting that the mother had some bleeding, or if there is a vasa previa, or if there is a history of a hemolytic setup. In that case, anemia can also cause a high output cardiac failure and sepsis. Sepsis screen can show any signs of infection, which may be the cause for respiratory distress. ABG analysis is another cornerstone for identifying a baby with distress. Now, the normal pH is between 7.35 to 7.45. That's when 7.35, you can call it as acidemia, 7.45 alkalemia. PO2 normal range for a preterm is between 50 to 70 millimeter mercury. Term is between 60 to 80 millimeter mercury. And if it is less than 50, you can call it hypoxemia. More than 80 in preterm and more than 90 in term, you can call it as a hyperoxemia. Partial pressure of carbon dioxide is normal range is between 35 to 45. Less than 35 is hypocarbia, more than 45 hypercarbia. Bicarbonate normal range is between 20 to 28. Base excess -4 to +4. Lactate should be less than 2. Once we have the blood gas, we can easily calculate the alveolar arterial oxygen gradient, the A ratio, oxygenation index, which we are comfortable with. Most of the times, this arterial gradient, A gradient, A ratio might be present in the APG itself. The normal range for A gradient is between 5 to 15, and it is considered to be abnormal, it is more than 40. For A ratio, should be greater than 0.8. If it is less than 0.15, it indicates severe hypoxia. Oxygenation index is useful when a baby is on artificial ventilation. And if the OA is between 25 to 40, it indicates severe respiratory failure. And if OA is more than 40, the mortality risk is like above 80%. This time I have to put in a chart showing the difference between a cyanotic disease, how to differentiate a cyanotic disease from a pulmonary disease. If you have a cyanotic disease, you may have a baby who is presenting with tachypnea rather than contractions. The heart exam may show weak pulses, hepatomegaly, a single S2, while the patient with pulmonary disease will have a split S2 because of the increased pulmonary pressures. Chest radiograph can show different shapes because of the difference in heart size. But in a pulmonary disease, there will be normal heart size, but you may see a parenchymal lesions. The ABG will have a normal or decreased partial pressure of carbon dioxide and a disproportionate hypoxemia, while pulmonary disease usually show respiratory acidosis with increased carbon dioxide and hypoxemia. If you do a hyperoxia test, you can differentiate between a pulmonary disease and a cardiovascular disease. It is done by doing a gas in 100% oxygen for 5 to 10 minutes and a gas in room air. And if the PaO2 is more than 250, you can confidently say that the baby is not having a cyanotic heart disease. Anything less than that, we have to investigate further. Now we come to the treatment of respiratory distress, or rather how to initiate treatment for respiratory distress. So all babies with respiratory distress need supportive therapy. The patient should be maintained in a thermoneutral environment, temperature between 36.5 to 37.5 degrees centigrade. If you have a doubt regarding the respiratory distress, like whether it is aggravating or whether it is severe, it is safer to start IV fluids. Antibiotics should be started in all cases where you're suspecting sepsis or pneumonia. Calcium glucose homeostasis should be ensured. Hypovolemia and anemia are to be treated adequately as necessary. The most common form of initiating support is oxygen therapy. For babies with mild distress, you can give oxygen via a nasal cannula. Indications being cyanosis or oxygen saturation less than 90. We have to target a saturation of 90 to 95. The usual one is a short binasal prongs, and we can give 1 to 2 liters per minute of flow in the binasal prongs. CPAP is cornerstone for treating or initiating treatment in a baby with respiratory distress. CPAP is recognized by NRP, is recognized by INCOR for delivery room stabilization of the baby. If you have a baby with a labored breathing at the time of delivery, especially if it's a preterm, it is recommended that the TP resuscitator be used for CPAP in the delivery room. CPAP can also be used for treatment of RDS, TTNP. It can be used for post-extubation stabilization and treatment of apnea prematurity. It can also be used for treatment of pneumonia, pulmonary aspiration syndrome, pulmonary edema, provided you have the facility to monitor and escalate treatment where necessary. Now, CPAP works by alveolar recruitment. It improves the functional residual capacity of the lungs. It helps to dilate the upper airways, splint the airway, decreases the airway resistance. Early CPAP is known to conserve surfactant stores and minimize stimulation of inflammatory cascade. For delivery room CPAP, we are advised to initiate CPAP with the 5 centimeter watt and FiO2 as necessary to maintain a normal saturation. You have to take care that a orogastric tube should be inserted for all babies on CPAP to decompress the stomach. Contraindications to putting CPAP is poor respiratory efforts. Now, CPAP can only be put in a patient who is able to maintain adequate spontaneous respiratory efforts. Otherwise, we can have a detrimental effect. The baby is having shock or hypertension, CPAP may not be the best choice. In case of congenital malformations of airway, coronary atresia, cleft palate, you may not be able to provide an appropriate CPAP. If there is a progressive respiratory failure, you have to escalate support from CPAP to other modes. Surfactant replacement is considered as one of the definitive treatment for respiratory distress syndrome. Dose is usually 100 to 200 mg per kg depending on manufacturer. Commonly used surfactants like Sarventa and Curosur. The dose is like 4 ml per kg and 2.5 ml per kg. The European guidelines that came in 2022 advise us to give Servanta, if the FiO2 required is more than 0.3 on a CPAP pressure of more than or equal to 0.6, or if the lung ultrasound suggests surfactant deficient. When to wean from CPAP? Once the CPAP pressure is come down to 5 and the FiO2 is reduced to 25 and patient shows no increased work of breathing, you can try wean from CPAP. Patient should not have any apnea, bradycardia, desaturation. CPAP failure is said when the FiO2 requirement increases to more than 0.6 and the pressure increases to exceeds 8 centimeter of water. High flow nasal cannula has come into vogue in recent years. Now, high flow nasal cannula was initially used to deliver oxygen, but various studies have noted that when you give a high flow, it also generates a distending pressure. But the distending pressure cannot be measured as to how much pressure the baby is actually getting. So there is that confusion. However, it helps to wash out the nasopharyngeal dead space and improves the carbon dioxide clearance. It reduces the infrared resistance. We are providing a heated, humidified gas, which helps to improve the comfort of the baby, reduce the mucosal injury. Now, HFNC is a lesser support than conventional CPAP. So, if a baby is having a mild distress, or if you think that CPAP baby, we do not need to escalate our CPAP support or improving, we can try HFNC support. Begin with a flow of 4 to 6 liters per minute, increase at 0.5 to 1 liter per minute as required. The prongs are designed so that it should fit loosely in the nares. We need continuous monitoring of heart rate, respiratory rate, saturation, work breathing. This is especially so because various studies have shown that if a preterm baby is put on primary support as HFNC, there is increased chance for failure and requiring escalation of respiratory support. So if you can monitor the baby, can try CPAP for a baby with a more mild distress.
The valves are closed. That is when it is done. It has to be done with in a apical 4-chamber LV focus.
It can be used as a step-down therapy from CPAP ventilation. Can be used for post-extubation support. Advantages are ease of use, lesser nasal trauma. It makes feeding and handling of the baby easier. Now, if the baby is not responding to your CPAP or your HFNC, and if the FiO2 requirement is increasing to more than 0.6 to maintain the target saturation, the respiratory acidosis is more than, it's creeping up with PCO2 rising to values of 60. The pH is coming down with a pH of less than 7.2, or the baby is having recurrent apnea. You should consider mechanical ventilation for the patient. When to refer the baby? It depends on multiple factors. What is the clinical status of the baby? Is the baby improving? Is the baby worsening? What is the degree of support which the hospital can provide? Is your hospital at level 1 center, level 2 center? Is there availability of personnel? Is there availability of equipment? All these factors in when we think about referring a patient with respiratory distress. Now, the last slide. For take-home message, I have to tell you that early recognition plays a key role. The baby is having distress. You have to recognize early. Delivery room CPAP is soon. It has reduced the number of intubations. Ongoing assessment is required to see whether the baby is improving or worsening. Early CPAP helps to conserve the surfactant stores. We can manage with an ensure technique surfactant replacement for mild cases. Always roll out non-respiratory causes of respiratory distress. Thank you.
Thank you, Dr. Manu. Everyone will agree that we have started our program with a bang, and it was quite a comprehensive comprehensive presentation about respiratory distress, including all aspects of distress in a newborn. So I think we'll take the questions. If any questions are there, we can put in the chat box, which we'll take at the end. Next, I think we'll move on to a small inaugural session. So for this, I would like to welcome, I think Dr. Riaz is there. Dr. Riaz.
I think ask Manu to stop sharing.
Okay. Yeah. Manu.
I think I have stopped sharing.
Okay. So I would like to welcome Dr. Riaz, IAP Kerala President, for a short inaugural address. Dr. Riaz? Riaz, sir?
Yeah, I could hear you. So
Ah.
thanks
Good
for the
evening, sir.
invitation. Yeah, good evening. Actually, I was traveling, so excuse me for switching off the video because the network is not very good. So I'm happy that we are having another episode of Essential Newborn Care Workshop. So this was actually envisaged during the initial planning of the Presidential Action Plan. And there is always a felt need for empowering pediatricians in treating neonates because they are always the first line. Because when a baby comes to the OPD with an acute problem, or be it in the labor room, it is the pediatrician who is called in. And with the advent of all the subspecialties and the development of neonatology, now pediatricians usually keep away from the normal neonatology practice. And over the time, they are all ill-equipped to manage immediate newborn problems. So that is why we consider to have such a program. And this has been done in various parts of the state. We did one in Trivandrum, we did one in Thrissur, and I'm very thankful to the NNF team for the whole support. So the last year office bearers, Jayaraman sir and Dr. Murali, which was continued by Joe sir and Nihas. And in Kochi, Dr. Thomas Ranjit and his team, as well as the IAP team headed by Bibin and Abhi, everyone has supported this program. I offer all the best for the online sessions and also the offline sessions scheduled for 31st. I give my apologies. I won't be available on 31st because the nutrition conference is coinciding. But on behalf of me, those are will be attending it. So all the best for the learning program and happy year. Thank you once again.
Thank you, sir. Next, we'll invite Dr. Jose, NNF Kerala President, for a short address, sir. Welcome, sir.
Good evening to all. Respected IAP State President Dr. Riaz, the NNF State Secretary Dr. Nihas, again NNF Ernakulam Dr. Ranjit, Dr. Gino, Murali Raj, Abhi, and KK Divagar sir, and all the faculties today joined here. I am also traveling, so there is some net issue. I am so some net issues are there. So I think Dr. Riaz mentioned this is one of the major action plan we are conducting for. I think it was initially started in 2003 when I am state president of IAP Kerala. Dr. Riaz was coordinated the program, and it was very much appreciated by all the pediatricians because they have the opportunity to update the knowledge regarding the neonatal care management. The topic are in such a way that all aspects of emergency management are included in the topic. And last year we are conducted and different honor work programs were conducted today. This is the second program conducting this year. One is Trivandrum is over, now is conducting Ernakulam this second program. I think these topics are very much useful for the practitioners for neonatal care is concerned. Today's the topic respiratory distress in newborn, neonatal hypoglycemia and neonatal hyperbiliemia. So that all three topics are very keen in neonatal management is concerned. Again, and the coming 2 days, again the Wednesday and Thursday, we are planning to conduct online program for the more important topics are included. And this basic knowledge is very useful for your offline program on 31st arranged at IMA Hall, Alva. I think during that program, they are conducting the offline program for non-invasive respiratory support, NRP, essential procedures, and again identification of a sick child and the role of X-ray and blood analysis, ABG analysis and newborn care management concern. I think this topic was very much essential for a newborn management is day-to-day practice is concerned. I think this topic, this program will very much useful for the practice in pediatrician and day-to-day practice. I wish you all the best, and we will meet again on 31st at UMA Alva for the offline program. Jai Hind, Jai EAP, Jai NNF.
Thank you, sir, for the wishes. Next, I would like to welcome all the delegates who have joined. I think we have had a very encouraging response. About 52 people have joined today. Thank you all. So without wasting much time, we will move on to the next topic, which is neonatal hypoglycemia. A very important topic in the newborn as it has implications for neurodevelopment. So it will be taken by Dr. Zakir Viti, who is the HOD and Senior Consultant, Renai Mid-City. Over to you, sir. Thank you.
Excuse me, Gino. There is one question in the chat box for Manu.
Should we take the question now or later?
I will answer that in just 1 second. So definitely, sir, the procalcitonin is useful, but the two things we have to note. One, there is a physiological rise in procalcitonin in the first 48 hours. So if you have a baby who is coming with a distress later after 48 hours, and if you are suspecting that the baby is having a bacterial infection, you can definitely do procalcitonin and confirm the sepsis.
Thank you. Thank you. Hope the answer is clear. Next, we go on to Dr. Zakir. Yes. Yes, sir. It is visible. Slides are visible.
Visible, okay.
Yes, yes.
Okay. So today I will talk about hypoglycemia in newborn. So as you all know, neonatal hypoglycemia is a very important topic and it is found up to 40% of newborns. Around 1/3 of babies belonging to risk categories to be screened for hypoglycemia, like preterm, infant of diabetic mother, LGA, HGA, IUGR babies. So they constitute around 1/3 of total neonates. But unfortunately, there is no consensus in diagnosing threshold, screening protocols, and treatment. So today I will talk about physiology of glucose regulation before and after birth, clinical features, at-risk population, diagnosis, screening, management, and outcomes. So the glucose regulation before birth, the fetus is entirely dependent on the mothers. And the mean blood sugar is around 54 milligrams per deciliter, which is around 2/3 of the maternal blood glucose. Maternal insulin is not crossing placenta. So the fetal blood glucose is maintained by maternal glucose levels and fetal insulin. As you all know, insulin is an anabolic hormone and it causes deposition of glucose as glycogen and lipogenesis, and it inhibits the lipid breakdown also. So what happened after delivery? So after delivery, the blood glucose in the newborn falls because the umbilical cord is cut off. So it becomes the lowest level within 1 to 2 hours of delivery. So plasma insulin level will fall and counter-regulatory hormones like glucagon, growth hormone, catecholamine, and cortisol will increase. So in the first 8 to 12 hours of birth, the glycogenolysis is the main source of energy and it is depleted by that time. So after 8 to 12 hours of age, gluconeogenesis should happen and it is produced from the lactate, glycerol, and amino acids. By 12 to 24 hours of age, the blood glucose concentration continues to rise and stabilizes around 43 to 90 milligram per deciliters. A newborn will reach the child or adult blood sugar levels by 2 to 4 days of life. You must also remember the best milk has very high ketone bodies, which is an important alternative fuel for the brain to make glucose. So this is what I told. So after delivery, what happens? The insulin level will decrease and glucagon level will increase. So causes lipolysis and gluconeogenesis is happening from glycerol, lactate, and amino acids. And glycogenolysis is happening, and ketogenesis that is happening in the liver by fatty beta oxidation from the fatty acids also. This chart shows the centiles of plasma and interstitial concentration of glucose in the first 5 days of life. But in the lowest line is the 10th centile. What we can see here, the blood glucose level is around 2.6 millimeters or the 45 milligram. That is usually taken as a cutoff. So clinical features includes sympathetic overactivity like irritability, tremor, jitteriness, tachypnea, sweating, pallor, hypothermia, tachycardia, exaggerated motor reflex, high-pitched cry, excessive hunger signs, vomiting, vasomotor instability, or poor sucking or feeding refusal. Or when blood sugar goes well below, it can cause neuroglycopenic symptoms like lethargy, listlessness, limbness, hypotonia, seizures, coma, apnea, irregular breathing, and cyanosis. These are the risk categories usually we screen, like prematurity, small for or large for gestational age, infant of diabetic mother, low birth weight, IUGR, perinatal stress, post-maturity because of placental insufficiency in that beyond 42 weeks also. All babies admitted to NICUs, in utero exposure to beta adrenergic drugs like terbutaline, in utero exposure to oral glucose lowering medications also, and rarely family history of genetic form of hypoglycemia or congenital syndromes like Beckwith-Wiedemann or Kabuki syndromes. So neonatal conditions also include clinical signs of poor feeding. That is an important. So usually the well babies are not screened, but if there is any symptoms of poor feeding, we should screen these babies. Cold stress, polycythemia, erythroblastosis due to hyperinsulinism, microphallus and midline defect due to pituitary defects, suspected infection. Sepsis is an important cause of hypoglycemia. Respiratory distress because of increased caloric need, or known or suspected inborn errors or endocrine disorders because of problem with the gluconeogenesis. So how will you define hypoglycemia? That is the most challenging situation. Whether we can define based on clinically, but it is difficult to define clinically because there are symptoms to it, and to develop symptoms it will take time. So we have to find out hypoglycemia before clinical symptoms. So it is not advised. So what about metabolic definition? Metabolic definition is defining hypoglycemia based on the counter-regulatory hormones, but we cannot measure counter-regulatory hormones during a feature of hypoglycemia because it is time-consuming. What about statistical definition, like below 2 standard deviation or all? But it is varying from gestation and depending on the time of delivery. So it is also not possible. And neurophysiological definition, like the newer technologies like somatosensory evoked potential, studies has shown it is not very conclusive. Neurodevelopmental definition also was, so many studies were done, but it was also getting any conclusive evidence. So we end up with the operational threshold definition that is followed in almost every unit. That is the glucose concentration when intervention is considered appropriate to minimize the brain injury. So we have two options to check the blood glucose, either by the point of care, a glucometer check, that's checking the whole glucose, which is usually around 15% lower than the plasma sugar. So we expect the lab sugar to be 15% more. But unfortunately, this is not the situation in most of the cases. We did the study and we found the POC blood sugars are often estimates. That means the lab sugar was often found to be low, unlike that is described in the textbooks. So the glucose level is also reduced if the hematocrit is high because of increased utilization by RBCs. And also processing can reduce the blood sugar levels from 6 to 10 milligrams due to increased red cell hemoglycolysis. What about continuous glucose monitoring? That is a research tool, but it is found to be safe and reliable and tolerated in newborns. But we don't know whether this continuous glucose, interstitial glucose monitoring has a useful role in screening and management and preventing the neonatal brain injury. So that is still a research tool. So this is one usually we follow. Even though it was made in 2011, the American Academy of Pediatric Consensus more than 15 years ago, but we still follow that. And in this, the late preterms, that is between 34 to 36 plus 6 weeks, and SGA babies are allowed screen for 24 hours, and infant of diabetic and large for babies are allowed, are told to screen up to 12 hours. And all symptomatic babies below 40 milligrams should be treated with IV dextrose. In first 4 hours of age, the blood glucose levels after feeding is not before feeding. After feeding, feeding should be given within 1 hour. And after 30 minutes of feeding, the first glucose is less than 25 milligrams. We give one more chance. We feed again, and immediately we check after 1 hour. If the blood glucose is going below 25 milligram, IV glucose along with the bolus is given as per this guidelines. And if the blood glucose is 25 to 40 milligram, we can either refeed or we can give IV dextrose as needed. So in the 4 to 24 hours of age, we give feeding immediately, and after feeding, we check the blood sugar. If less than 35, we give one more chance and feed immediately within 1 hour, and it goes below 35 milligram, we have to give IV dextrose. But 34 to 45 milligram, we refeed and give IV glucose as needed. So this was a consensus that is given in UpToDate based on the AAP guidelines and the Pediatric Endocrine Society, that is guideline which was made in 2015. So the PES guidelines or Pediatric Endocrine Society, they have a little higher threshold. Actually in 1980s, the threshold was around 20 milligram for hypoglycemia. Now it has increased over the years, and now as per the Pediatric Endocrine Society, they want to keep the blood sugars around 50 milligram in symptomatic babies and more than 48 hours around 60 milligrams, but they keep the same levels. And first 24 hours, below 25 milligram is the threshold for interventions, and 4 to 24 hours, that is 30 milligrams. And in the first 24 to 48 hours, it is again kept around 50 milligrams, and more than 48 hours around 60. But if you suspect any hyperinsulinism or other inborn or other primary hyperglycemia disorders, we need to keep a higher target around 70 milligrams, and threshold 90 to 100 milligram is taken as the upper limit. In NNF guidelines, the first 24 hours it is 25 milligrams, or after 24 hours it is more than 45 milligrams. So whatever guidelines, we should have a guideline in our unit to follow the hypoglycemia protocol. So what will you do if severe hypoglycemia? Definitely we need, or if the blood sugar is very low means the blood sugar less than 20 milligram as per NNF, or less than 18 milligram as the British perinatology guidelines, and it also varies from different guidelines. But if the blood sugar is severely low, less than 20 milligram, or baby is symptomatic, we have to give intravenous fluids with maintenance of 5 to 8 milligram per kg per day, along with the bolus of 2 ml per kg. So glucose should be measured after this 30 to 45 minutes of bolus, and encourage breastfeeding always along with the intravenous fluids. And we target 50 milligram during the first 48 hours and 60 milligram after 48 hours. And repeat blood sugar 30 to 45 minutes. If you increase blood sugar, IV fluids, it is better to repeatedly check and maintain the blood sugars above the target levels. So how will you wean the dextrose? So the weaning, the maximum dextrose administered, the peripheral IV line is 12.5%, as we all know, and through the central line, it can go as high as 25%. And weaning is typically started when the infant blood glucose have been in the target range for at least 6 to 9 hours. So we can wait for 6 to 9 hours to make sure that blood sugars are maintained. Then we start tapering the blood glucose. And glucose infusion rate can be tapered slowly and transition to oral feeds. How much you will wean? They're telling around 1 to 2 milligram per kg every 6 hours, and we stop IV fluids at 4 milligram. So 1 milligram, if the blood glucose is on the just above the target range, and if the blood glucose are going very high, you can even wean 2 milligram per kg every 6 hours. And blood glucose, if it's going below 40, we have to increase 2 milligram per kg per minute, and you have to check the blood sugar levels after 30 to 45 minutes until glucose is in the target range. This is the same thing. If severe symptoms, you have to give bolus, and you have to increase the blood sugar 2 milligram per kg per minute. So milligram per kg per minute is very important, not based on IV fluid ml per kg. because we are giving oral feed also. So it is always better to follow the milligram per kg per minute. So there are many GIR calculators. There are Starship calculator, which includes IV fluids, and also the breast milk. Breast milk is also included in that. That roughly comes dextrose into ml per kg per day divided by 144. So if you give around 70 ml per kg of 12.5%, it comes around 6 milligram, and 90 ml per kg of 10% dextrose will come around 6 milligram per kg per day. So these are the various protocol for weaning blood sugars. So what will you do in asymptomatic and mildly symptomatic? Mildly symptomatic means jitteriness is considered as a mildly symptomatic. In these cases, we need not give IV bolus or IV fluids if there is mild jitteriness, because it's considered as mildly symptomatic patients. So the first line is always breastfeed and formula. Continue breastfeeding until the accepted target range. If we follow 45 as NNF guidelines or the Pediatric Endocrine Society of 50 milligram per kg per day. On pre-feeding, after maintaining the blood sugar, we always should make sure the pre-feeding sugar, not the post-feeding sugar, every 3 to 6 hours in the first 24 to 48 hours. If infant sugar is going less than 45 milligram also, after 2 to 3 feeds are in the borderline sugars, we can also consider intravenous fluids. So dextrose gel was found to be effective and is given in the developed countries. In the sugar babies trials, it found it reduces the admission more than 40%, but unfortunately, we don't have the dextrose gel in our country that can be given only for asymptomatic babies. So how to monitor? As I already told, you have to monitor every 3 to 6 hours routinely in the preprandial sugars. And if at least 3 plasma glucose levels are going above the target levels, we can stop monitoring, and baby can be discharged. But some people consider the higher than 50 milligrams, 60 or 70 milligrams, but it can only prolonging the hospitalization and increases unnecessary investigations. But persistent hypoglycemia, that is persisting more than 4 days, or if we need IV fluids, and in those cases, if we suspect a persistent hypoglycemia, better to keep 70 milligram as the target, as I told earlier. So persistent hypoglycemia, there are various definitions in that, and that is the hypoglycemia is persisting beyond 48 hours. Some books say more than 4 days or 7 days, but after birth and the requirement of intravenous fluid infusion to treat hypoglycemia beyond 48 hours can be taken as persistent hypoglycemia. The persistent hypoglycemia can be due to a transient problem only. It may not be always due to some pathology, but it can be a transient hyperinsulinism, as in small for gestation or infant of diabetic mothers. But we must be very careful. It is a red flag if the hypoglycemia is persisting more than 48 hours. We must also remember there is no need to do a critical lab generally until 96 hours as per the guidelines, and more than up to 3 days as per Canadian guidelines after birth, to make sure that the transition period of hyperinsulinism and other causes are over. So in that cases, we can send a critical sample if the blood glucose level is less than 50 milligram per deciliter after 3 or 4 days of life. Investigation includes the hormones like insulin, cortisol, growth hormones, and fatty acids, beta hydroxybutyrate, lactate, ammonia, and urine ketones. So red flags includes the requirement of prolonged and high rates of IV dextrose, more than 10 to 12 milligram per kg per day. And also babies, there are no risk factors for hypoglycemia, persistent hypoglycemia, family history of genetic hypoglycemic disorders, or physical. Clinical examination is always important, as told earlier, that if I have any suspecting any Beckwith-Wiedemann syndrome or congenital adrenal insufficiency. In these situations, we should include other subspecialties like endocrinologists or metabolic experts. So what about neurodevelopmental outcome? We are all worried about the neurodevelopmental outcome in hypoglycemia. Actually, it was suggested 60 years back by Kornbath and Reisner, established that hypoglycemia can cause mortality and morbidity. But the outcome of children with asymptomatic hypoglycemia studies are still not clear. And that's the most important study was the children with hypoglycemia in later development study prospectively followed 528 infants, more than or equal to 35 weeks of gestations. And they checked the blood sugar by interstitial blood glucose, continuous glucose monitoring, and they found that at the mean age of 4.5 years of age, there was a problem with the executive and visual motor functions. But when they followed at 9 years, they could not find any problem even in asymptomatic hypoglycemia. But we know that symptomatic hypoglycemia definitely causes problems, and we have found injury in the MRI, mainly in the occipital region, or even other areas like parietal and other regions as well. So, but there are no available data that clearly define below what level it causes the brain injury, or how long the hypoglycemia should persist to cause the brain damage, and it was still not known. A systematic review on symptomatic hypoglycemia published in 2006 also reported there is inconclusive evidence on the neonatal hypoglycemia and neurodevelopment. So, in short, it remains uncertain whether timely treatment or of hypoglycemia will prevent the brain injury and poor neurodevelopmental outcome also. So these were the target I told earlier. So to take home message, all stable infants should initiate breastfeeding as soon as possible, preferably within 30 to 60 minutes of life. And first we check the blood sugar after 30 minutes of feeding. And then if stable, we can check 3 to 6 hour preprandial sugars. Hypoglycemia cutoff is variable, less than 36 milligram first 24 hours and 45, less than 45 beyond 24 hours, maybe in NF guidelines. And the AAP guidelines I already discussed, and the varies from guideline to guidelines. Symptomatic hypoglycemia should be aggressively treated if sugar is less than 40 to 50 milligram per deciliter, and prevention of hypoglycemia by screening the at-risk babies is very important. Always confirm the blood sugar levels, the POC levels with blood sugar lab values, because there is, even though we found that there is a lot of variation between the lab values and the point of care glucometer values. So we usually send even below 50 milligram to the labs. So these were the references, few references. Thank you.
Thank you, sir, for the exhaustive review about hypoglycemia. Sir has covered screen that which all babies should be screened, and about the ambiguity in the levels of blood sugar which should be taken. I think 2 cutoffs can be taken: less than 48 hours 50, and more than 48 hours I think it should be kept above 60. And then the very important aspect of management and neurodevelopmental outcome. Thank you, sir. Any queries can be put in the chat. So next we move on to the most common and important topic, that is neonatal hyperbilirubinemia. We have Dr. Murali Raj, who is a consultant neonatologist at Kraft Hospital, for the next talk. Thank you, sir. Welcome, Dr. Murali.
Yes. Thank you, Gina, for the introduction. And then also I would like to thank IIT Kerala for this opportunity. So this PowerPoint window, continue to share. Yes. Okay. I think I am visible and audible.
Yes, visible. Yeah.
Okay. So good evening, all. Actually, Gina has given me a Herculean task of concising hyperbilirubinemia in 15 to 20 minutes. I don't know whether I'll be able to do justice, and anyhow I'll try. So probably for all pediatricians, and we care for the newborns, and it is one of the most important or one of the most common diseases or situations where we have to manage ourselves. So newborns are jaundiced. So if you take into the adult criteria, that is the serum bilirubin level of more than 1 milligram per deciliter, almost all newborns will be jaundiced. 85% of term babies, or almost all preterm babies, will be clinically jaundiced. And almost 6% of newborns will have a total bilirubin of more than 13, and almost 3% of normal term infants will be having a total bilirubin of more than 50 milligram per deciliter. So what is the importance of this slide is that almost all newborn babies will be jaundiced. So our job as a pediatrician is to differentiate to which baby will be going into complications, or we have to identify early who our needs intensive treatment, who our needs intensive monitoring. So as this slide clearly says that jaundice can be, vast majority it can be a physiological one. It is just a enlarged discoloration of skin and sclera. I apologize for that spelling mistake, it is retrosclera. And it can be 5% can be pathological, where you have to do intensive things. Can be from a simple jaundice to bilirubin-induced neurological dysfunction. So the line of demarcation is what we need to identify early. Why newborns are jaundiced? We all know that because they have a high amount of RBCs, and the lifespan of the RBCs is less because only it is 90 days. So they'll be broken down and it will be converted into bilirubin. And reduced clearances also will be there from the liver because of the immature liver enzymes. And whenever it is excreted into the intestine, there can be more enterohepatic circulation in the case of newborns. And this bilirubin will be reuptake into the circulation. So all these reasons, newborns are jaundiced. This is like pathological and physiological jaundice. We all know that any jaundice which is less than 24 hours is a pathological jaundice. And the rate of increase of bilirubin will be faster in pathological jaundice. So it will be more than 5 milligram per deciliter per day. Or more than, if you do it on an hourly basis, it will be more than 0.2 milligram per deciliter per hour. Whenever the conjugated bilirubin is more than 1, which is persisting more than 2 weeks, and abnormal examination findings will also be there because most of that conjugated jaundices or abnormal bilirubin, which is persisting more than the 2 weeks of time, will be associated with can be associated with abnormal physical examination findings like hepatosplenomegaly or bleeding spots or sepsis or congenital anomalies, anything like that. Whereas in the case of physiological jaundice, the rate of increase will be less. Conjugated bilirubin will be essentially less than 1, and almost all of them will resolve by 2 weeks. And there will not be any abnormal clinical examination for these babies. So, if you want, what as usual, as pediatricians, what we see, the third day we go for the routine rounds and we see a baby with jaundice, and we just do a clinical assessment. Some of we do that serum bilirubin estimation and sees that it is 16, and we tell the staff that give a phototherapy for 1 day, repeat it next day and see it's 10, 11, okay, happy discharge, everything. And the story goes on. Usually, majority of us, including me, won't take history. So why history is important in neonatal hyperbilirubinemia? Yes, it is very important because sometimes serocytosis, sometimes liver disease, lactoseme, or for jaundice, Southeast Asia, jaundice or anemia. We usually don't take this history. Whenever when the bystanders tell us only these things, will be giving importance to these points. So it can be a blood group incompatibility or RHI or OA, OA incompatibility can be there, or can be a breast milk jaundice. So family history is very important. We may miss any of this if you take these things superficially. And coming to this pregnancy history and illnesses during pregnancy, like congenital or viral infections, infant or diabetic versus, we know that the chance of jaundice is high, and any drug intake by mother, and difficult delivery like birth trauma, hypoxic ischemic insult can cause this intracranial bleed or liver dysfunction. And delayed cord clamping, which is a routine practice now, can cause an increased risk of neonatal jaundice, but it is never, because that benefits of DCC or always is more than when we compare to this mild increase in the jaundice. And assault in infants, that will be taking the history of this feeding and this stooling of the babies and vomiting like sepsis or pylorostenosis or galactosemia. So this history is very important. So depending upon this history, we can do the risk stratification for these babies. A preterm baby, a jaundice within less than 24 hours of life, a pre-discharge transcutaneous bilirubin, we come to that, or total serum bilirubin concentration close to the phototherapy threshold. Yes, these are all risk factors. Hemolysis from any cause, phototherapy before discharge, parent or sibling requiring phototherapy or extended transfusion, family history, that breastfeeding with a suboptimal intake, scalp hematoma or significant bruising, Down syndrome or macroscopic or infant of a diabetic mother. So these points clearly tells us that this particular baby is high risk for developing jaundice in the next 1 or 2 days. So always be cautious while dealing with these babies. What is the role of visual assessment? We all do that. We all do visual assessment when we go for the routine postnatal rounds. So it is recommended that you should do the visual assessment every 12 hours following delivery. And transcutaneous bilirubin or total serum bilirubin will help you to supplement or reiterate your visual assessment. So this is one of the first scale or chart. It is for use for pediatricians. It is actually Palmer's scale, which is published in the Archives of Childhood Diseases in 1969. We all do these things, even though we don't remember these values like dermal zone 1, 2, 3, 4. But in your day-to-day practice, we all do this. It needs a natural light. It's definitely personal experience, and there can be subjective assessment. I'm pretty sure that we will be doing in our postnatal assessment as well as when the babies come for follow-up up 2 weeks or 3 weeks. At least we'll be doing the salt staining. So we'll be just seeing the soul of the babies, press it and see whether it is jaundice or not. The yellowish discoloration is there or not. At least it will help us to tell that the bilirubin value is more than 15 milligram per deciliter and the need for intervention. So it is currently recommended that a total serum bilirubin measurement complement the clinical assessment for jaundice in every neonate during birth hospitalization to assist in hyperbilirubinemia detection and neonatal management. So initially, a clinical assessment, which is followed by a total serum bilirubin estimation. What is transcutaneous bilirubin? So I don't know whether all of you know about this instrument. This is a transcutaneous bilirubinometer by Dragon, which costs about 2 to 3 lakh rupees. And usually it is a non-invasive one. There is no pain while doing serum bilirubin measurement using this instrument. But the thing is that whenever this transcutaneous measurement correlates well with the serum bilirubin level when the bilirubin level is less than 50 milligram per deciliter. So it is a tool for screening. And if the transcutaneous bilirubin is more than 15 milligram per deciliter or within 3 milligram deciliter of phototherapy range, suppose the phototherapy range is 17 for a baby and it comes as 40, then it warrants TSB, that is total serum bilirubin assessment. So it can be used in different races and gestation age. But if you have started phototherapy for a particular baby, it is not useful for monitoring the baby while the baby is on phototherapy. So at least you have to wait 24 to 48 hours to reassess the transcutaneous bilirubin while using these instruments, because there is some discoloration while the baby is on phototherapy. So there is a good correlation between this transcutaneous bilirubin measurement and total serum bilirubin when it is generally within 3 milligram per deciliter. That is the difference is there. And also when the serum bilirubin is less than 50 milligram per deciliter. So whenever the serum bilirubin is more than 50 milligram per deciliter and the difference is more than within 3 milligram per deciliter from the phototherapy range, you have to do the serum bilirubin assessment. So TCB, that is transcutaneous bilirubin, is mainly used as a screening. You can take it to the postnatal rounds, you can measure it. Definitely it is a helpful tool. Only thing, it is expensive. So how to decide on treatment? All these issues, that is plasma bilirubin level, risk factors, polycythemia, prematurity, feeding issues, associated diseases or family history. Then comes our specific bilirubin nomograms. We have a lot of charts are available. Initial chart was by American Academy of Pediatrics 1994. They are modified in 2004. Again, ALP modified the charts in 2022. And NHS chart is also available. It was last time it was modified in 2010. I'll be discussing very briefly about these charts, that is 2004 and 2022, and also I'll go briefly through the NHS chart. So this is the classic Botany chart that we used to study in junior post-graduation days. And this is actually a risk stratification chart, that is pre-discharge, that is before discharge. If you want to make the baby, put the baby into a particular risk zone, you can use this chart. So by this chart, the baby is stratified into low risk, low intermediate, high intermediate, or high risk zone. And what is the importance of this is that fortunately, after the discharge, you can recall for the review. And so straight this phototherapy chart, and the advantage of this 2004 chart is that all category of babies, like high risk infant, low risk infant, or medium risk infant, the data you'll get in a single sheet. Only thing you have to know what are the risk factors. So this is there. It's RHI incompatibility, GCSPD, significant lethargy, temperature instability, sepsis, acidosis, or albumin less than 3 gram per deciliter. So in this case, anything is there, the baby comes in the red line. Or no risk factors, baby comes in the blue line, and medium risk factors. It is written in the down here. What do you mean by medium risk? And medium risk comes in the green line. So always you can have a printout of these things in your NICU or ward and have for a quick reference. Also, this 2004 guideline gives clear indication to do this exchange transmission. Then comes the 2022 recommendations. So 2022 recommendation is a little tricky one, and actually the target for a normal baby who is having no risk factors is actually they have made it high. And whenever the risk factors are there, they are made aggressive also. So depending upon this, you have to identify the babies with the risk for neurotoxicity. That is the gestation age less than 38 weeks, albumin level of less than 3 gram per deciliter, any immune hemolytic anemia, GCSPD or any other hemolytic conditions, sepsis, or clinical instability in the previous 24 hours. So these points towards a high risk for neurotoxicity. According to this chart, there is a algorithm. They are given an algorithm. So this is the algorithm for the approach to hyperbilirubinemia as per the American Academy of Pediatrics 2022 guidelines. Whether the mother is having a RH isoimmunization or any blood group incompatibility, whether she is having that or not, all mothers should be screened for maternal antibody. So that is the ICT, the indirect Coombs test has to be done for all mothers. And if it is done and it is not positive, okay, the baby comes naturally in the low risk group and you can apply the standard charts. And suppose the maternal antibody screen is not done and it is done and it is positive, then you have to do the direct Coombs, DCT, that is direct antiglobulin test for the baby. And also you have to do the blood group. And suppose the baby is DCT is negative, yes, again, then it is low risk. And if it is DCT positive, then you have to identify whether the DCT positivity is due to the anti-D which the mother already have received, or it is due to real RHI isoimmunization or whatever isoimmunization the mother and baby may have. And if it is due to the RHI isoimmunization, then the infant has a high hyperbilirubinemia risk factor. That need not be RH, it can be any other minor blood group or any other thing. Then immediately you have to measure the transcutaneous bilirubin. Then every 4 hours 2 times and every 12 hours 3 times. And always you have to follow the standard charts for deciding whether to give phototherapy or exchange, whatever it is. So this is the initial assessment for a baby. You have to do the maternal antibody screen. And if it is not done, there is a protocol. If it is done, and you have to do the DCT for the for the baby. And if it is the DCT, if it is negative, yeah, okay, fine. And if it is positive, you have to identify whether it is due to the anti-D which is given to the mother, or it is due to the isoimmunization for the baby. And depending upon that, you have to decide to which way you have to go. So when there is no neurotoxic risk factors, you can clearly see that the phototherapy threshold has increased. Whenever we are practicing, so you can see very well see that whenever there is no neurotoxicity risk factors, if you see 72 hours the serum bilirubin of 20, we need not do any phototherapy. So I don't know whether in the practical causes fatigue scenario. Whether we will wait for that, I'm not sure. But AAP clearly says that you can wait up to 20 milligram per deciliter. Whenever the baby is 72 hours old and 96 hours old, you can see that you can wait up to 22. Whenever there is no neurotoxicity risk factors or when the baby's term. When one or more neurotoxicity risk factors is there, again the charts are clear, and you can at 72 hours you can see that it is almost 17 milligram per deciliter. So this is the threshold for extended transfusion. You can see that for my 72 hours, it is saying when there is no risk factors, you can wait up to 26 milligram per deciliter. And when there is neurotoxic risk factors, actually you can wait up to 22 milligram per deciliter. So these are just guidelines, and these charts are available freely in the internet. You can have a printout and keep it in your ward or an ICU, or you can keep it in your phone so that for the ready references. It is very difficult to remember all these things by heart. Not difficult, it is not possible. So it is better to keep it as a soft copy or a hard printout in your ward or an ICU, and you can have a ready reference for these things. The thing is that these charts are actually having 35 weeks and above references. And what you'll do if you get a baby with less than 35 weeks? And in this, actually, AAP doesn't have a clear-cut answer for that. But this NHS that is gives a chart. You can have a ready reckoner for this babies who are having less than 35 weeks. So actually, this comes in the Excel format. Sorry. I'm not sure it will open or not. Yes. I think you can see the Excel sheet. Actually, this Excel sheet you can download and you can keep it in your tab or computer. And the thing is that everything is available in this Excel sheet. Suppose it is also, you'll get an answer. There is no confusion regarding this. Suppose this baby is more than 38 weeks gestation, and phototherapy zone is this, because only thing that it is given us this micromole per liter. So how will you change into milligram per deciliter? Just divide by 17, 17. You will get in the milligram per deciliter value. So if you want to have a baby, we want to have a data for a baby who is having 35 weeks of gestation. Yes. Then again, this Excel sheet gives you a clear-cut guideline, whether to do the exchange or whether to give phototherapy. So it is given in micromole per liter. So you have to divide it by 17. Suppose you want to do it for a 25-weeker. Yes, again, we got the answer. So this is more or less a user-friendly chart, NHS chart. And you can always, it is available in the internet also. You can always download and keep it in your mobile and for the ready reckoning. So this is the advantage of NHS guidelines. That is available from 23 weeks of gestation in the Excel format. It is available, and there is a threshold for phototherapy and extended transfusion is available in the same sheet. So it is more a user-friendly chart. So whatever chart you use, it is important that you stick on to one chart, and you can have a protocol depending upon the chart which you are following. It's not mandatory that you should follow the American Academy chart. You can have NSS chart also. Do it that. So this is another guideline that is not guideline, it's a continuation of the AAP guideline, that is infants during birth hospitalization to determine post-discharge follow-up. The thing is that baby, you have to measure that transcutaneous bilirubin or total serum bilirubin if the baby is more than 12 hours old. And determine our specific phototherapy threshold based on gestational age and presence of a non-hyperbilirubinemia risk factor. And measure the transcutaneous bilirubin or the total serum bilirubin. And if it exceeds more than 50 milligram per deciliter, or the difference is 3 milligram per deciliter, within that you can discharge the baby. And the thing is that if it is above the phototherapy threshold, you can start phototherapy. If it is not, you can discharge. While discharging, you should always have a plan to call back all these babies for the review. So suppose the difference for phototherapy is within 2 milligram per deciliter. If you are discharging the baby less than 24 hours, okay, you know that baby is only 24 hours old and it is already close to the phototherapy threshold. Either you can consider phototherapy or you can delay discharge. So like that, clear-cut references are given in this recommendation. But in our Indian scenario, we never discharge, or some other hospital I know, but usually we don't discharge mother and baby within 24 hours of delivery. So if you are discharging on second day, third day, or on an LSES on fourth day or third day or fourth day, you can have these charts, because if you are discharging more than 72 hours and your bilirubin level is within 5 to 7 milligram per deciliter from the phototherapy threshold, you should call them back within 2 days to have the clinical assessment. So there's no confusion in this. The away from the phototherapy threshold, you are safe. If it is close to the phototherapy threshold, just call back after 12 hours, after 2 to 3 days to have a clinical judgment whether the baby has progressed the jaundice or not. Coming to escalation of care, suppose the baby is in the phototherapy zone, or his jaundice is in the exchange zone, or whatever it is. Suppose if you are in a location of facility for exchange transfusion, yes, you can have all the investigations like direct bilirubin, blood type, serum chemistries. You can inform the blood bank and measure serum bilirubin every 2 hours and adequately hydrate the baby and start IVIG if needed. And if you are having no facility for this exchange transfusion, it is better to ship the baby to an adequate center. Assess the baby. Suppose the baby is having severe jaundice and you are having facilities for exchange transfusion. Assess the baby for signs of bilirubin encephalopathy. If it is there, you have to do the urgent exchange transfusion. And if there is no, you can continue the intensive phototherapy while you can arrange, hydrate the baby, feed the baby, you can give intensive phototherapy and do the exchange transfusion when the blood is available. So this only we have covered. So optimizing phototherapy, usually we do the blue light phototherapy. Initially, the intensity for the light usually be 10 or 15 microwatt, but now it is recommended intensive phototherapy only. So the irradiance should be more than 30 microwatt per centimeter per nanometer. LED or CFL lamps are available. A periodic check of the intensity is needed. This is what usually we don't do routinely. At least it's actually operator dependent. The manufacturer will tell you how frequently you have to do that radiance or lux radiance measurement. At least once in 6 months, you have to do that. Maximum area has to be exposed while putting the baby on phototherapy. Yes, another baby on phototherapy, you can have actually the diaper should be smaller than this. Eye should be covered, the entire area should be covered, and other than that, all maximum area should be exposed. And you can light source, as I already told, it can be LED phototherapy. I think we all have shifted to LED phototherapy. We don't have the CFL lamp or any other fluorescent phototherapy. So I'm skipping the halogens area. Another one is Billy blanket, that are fiber optic blankets or pads under the infant, though. The advantage is that the maximum area will be exposed, and the good advantage is that you can handle the baby, you can feed the baby while the baby is having on Billy blanket, and also it is good for home phototherapy. If you are early discharge and they want to give phototherapy at home, Billy blanket is a good option. So handy also, you can take anywhere, you can transport it also, unlike that standy one. This device has to be periodically checked for that light source and irradiance. Whenever we change the bulb or whenever we do the service, we have to check the radiance of that meter. Strategies can be continuous, that is the baby is uninterrupted, the baby will be full time in the phototherapy, or it can be continual, that is brief interruptions for baby handling, parental bonding or breastfeeding. And intermittent phototherapy is also there, that some minutes to hours we will be switch off the phototherapy and the baby will be kept on the warmer, and after that we will start the phototherapy. And usually it is done for extreme limits of babies when they cannot tolerate this high intensity phototherapy. And feeding has to be continued. Phototherapy, the bilirubin has to be checked every 12 hours or 6 to 12 hours starting phototherapy. And if the jaundice is very high or nearing the extent transfusion, you have to check it in 2 hours. Always clinically monitored. Weight has to be monitored. Temperature has to be monitored. Hydration status has to be monitored, and you have to continue the breastfeeding. Extent transfusion, we know what are the indications. We have charts with us. Always stick onto the chart. And if you are having the signs of BINT, that is bilirubin-induced neuronal damage, that even if the serum bilirubin is falling with your intensive phototherapy, you have to do the extent transfusion. And whenever the baby is anemic, that is the hemoglobin less than 10 or bilirubin is more than 5, it is better to go for exchange. And in hydrops or non-immune hydros, the treatment option is extent transfusion. I'm skipping this because it's this beyond the scope of this presentation because the bilirubin and albumin ratio. So there is no routine use for IV fluids, IVIG, phenobarbital, probiotics, antibiotics, or sunlight exposure, or stopping the breast milk. Even in cases of the breast milk jaundice, you need not stop breast milk. IVIG, okay, it can be given at a dose of 0.5 to 1 gram per kg over 2 hours. Provided the infant is isoimmune hemolytic disease, that is a post-Coombs test. If you are working in a secondary care, always remember when to refer the baby, that is total serum bilirubin or at a double body exchange zone, that is more than 20. Actually, 25 is not the correct value. It is for that's a time-dependent one. In 72 hours, you are checking the bilirubin. Uncomplicated babies, this is more than 26, and any risk factor for hyperbilirubinemia, it is 22. There is no response to phototherapy. There's hemolysis is there. When the sick baby, you have to refer these babies. So usually we give phototherapy on and off very frequently. If you suspect the jaundice is there, without even doing the serum bilirubin, we do that phototherapy, thinking that it is a very benign therapy and nothing will happen to the baby, but it is not correct. Anything comes with a cost. So they can be oxidative stress, lipoperoxidation, dehydration, hemodynamic issues, diarrhea, retinal damage, mother and baby separation, prolonged hospital stay for phototherapy, and exchange, a lot of complications the baby can have like this. I'm not explaining all those things because of the lack of time. So the take-home message is never stop breastfeeding in neonatal jaundice. Do a risk assessment at discharge. Written instructions at discharge. Interpret total serum bilirubin values with the gestational age and hours of life. Start and stop phototherapy according to the standard graphs. Also, charts are your friend on deciding the treatment, or even if it is medical legal aspect, charts are your friend. Always stick onto the chart, and you'll be able to able to get that decision making will be simpler if you stick onto the chart. So always have a risk benefit ratio while you are dealing with a neonatal jaundice. Don't think that it is a benign treatment and we can do phototherapy 3-4 days now. That is, if it's not needed, don't give. Always assess. Always check the bilirubin, and if it is needed only, give the phototherapy. Thank you. Thank you for patient listening.
Thank you, Dr. Murli sir, for this exhaustive presentation. I think sir has stressed upon all the aspects of jaundice. And to name a few, always screening all the babies who are discharged from the hospital should have a serum bilirubin before they are discharged, and follow-up should be stressed. And then always find out which baby requires escalation of care, and an early referral is the motto when you don't have the facility for doing exchange transfusion. Thank you, Dr. Murali. Any questions in the chat box?
Breastfeeding jaundice treatment. Yes, breastfeeding jaundice treatment, it's the same as the neonatal jaundice treatment. Only thing that you have to reassure the parents that it is due to breastfeeding only. So breastfeeding jaundice, usually when that comes for review after 2 to 3 weeks, you will be seeing the baby is jaundiced. So you have to make sure that it is a breastfeeding jaundice only, because make sure that what is the stool color, what is the any other physical abnormalities like hepatosplenomegaly or bleeding spots. One of the things you have to keep in mind is that the conjugated jaundice that can happen at this age group, it is not there. If you're 100% sure that it is breastfeeding jaundice, you can reassure the parents. And suppose the serum bilirubin goes very high. Suppose there are case reports that tinnitus has happened due to breastfeeding jaundice. There are extent transfusion has been done as a treatment modality because the serum bilirubin went above 30 milligram per deciliter for breastfeeding jaundice. So the other things are rare things. You can always reassure the parents, and if needed, you can give phototherapy, no problem. And one of the important things is that never stop breastfeeding. I see a lot of doctors stopping breastfeeding. Yes, if you stop breastfeeding, the jaundice will come down because breastfeeding is a triggering factor. So jaundice will come down, but that's not the way we should manage breastfeeding jaundice.
So one question was, is oxygen therapy, which SpO2 level should be maintained? I think it has been answered. 90 to 95% is adequate. But only thing which is while giving free flow oxygen, sometimes we may be giving a lot of oxygen to maintain 90%. So never be happy with a saturation of 90% when you are giving a lot of oxygen. So you have to assess the baby carefully. So Dr. Thomas, can we?
I think we can wind up. It is a little bit overshot, I think, by half an hour or something. In between, we had an inauguration, so can be excused for the time being. And when the people who are attending the class, please make sure that the mics are off. ഇല്ലെങ്കിൽ ആരുടെയൊക്കെ വീട്ടിൽ അരി വെക്കുന്നുണ്ട്, ഏതൊക്കെ കുട്ടികളാണ് ഹോംവർക്ക് ചെയ്യുന്നതെന്നൊക്കെ എല്ലാവർക്കും അറിയാൻ പറ്റും. അതൊന്ന് ശ്രദ്ധിക്കുക. But otherwise, I think tomorrow 30 we'll meet again. It's been a long session. I think we can wind up. Thank you.
Thank you all who have stayed throughout the time. And tomorrow